Greetings, students. Welcome to IPE 2100 Global Panel. As you can see, we have a distinguished visitor here. And we are in the recording studio in the basement of Pius Library, and we are really excited to be using this space for this. But here is the venerable Dr. Powers. Or Dr.
Hi.
Power, and we're really excited to have her here live to help conduct the global panel. I'm going to turn it over to Alison and let you get us going.
Brilliant. Hi, everybody. So yeah, I'm in the same room. Look, I'm over in St. Louis, got here yesterday, really excited to be here. And obviously I'll be seeing everybody in class again, face to face on Monday. So let's get going with today's session. So you would already have seen, I put on Canvas the short bios of all our very esteemed speakers today. We're so delighted to have 5 people who are really high in the field of IPE globally. So we pulled in lots of favours to get them here. Well, no favours. No, we're not giving them anything. They're not being paid, but we're delighted that they've all been able to join us, and we'll be going to each person in turn to ask them 2 specific questions. So you'll see that's just a reminder of the bios. And we're going to go through with each person, and they're going to introduce themselves and then talk a bit about the health and social care systems in their own countries, and just having a look at what works well and ongoing challenges. And then we're saying 5 minutes per person, so I will be very rude and move between, because it's going to be really nice to have some kind of discussion at the end between all of our speakers, but also hopefully the class will get involved. You know, you get points make prizes if you engage, so it'd be really good if you can we can have some interaction for our guests. So could we go with Champion first? Is that okay, Champion? Oh.
Yeah, it is okay.
On share.
Yeah.
Can you hear me?
Give us 1 second. We are going to let you be in the big screen here. There we go.
There we go.
Good. Champion, we can hear you. Yes.
Okay, fantastic. Good evening, everybody. And as stated, I'm Champion. I'm from the University of the Free State in South Africa. Originally from Zimbabwe, have worked in quite a number of countries in Southern Africa and have students across the continent. Just for orientation, South Africa is part, or I could say geographically, the tipping point of the African continent. Quite an interesting history and dynamic. But straight to the health system and the social care system. So officially, it's described as a dual structure type of system, where you have what they call the public health system and also a private health system. And I often want to add a third structure of the health system, which is the traditional or the alternative health system, which is often not discussed within the mainstream type of healthcare, but we'll get to that. So within the public health system, it caters for about 84% of the population in the country. It's often through our funded by the state. And the idea is to provide universal health coverage, meaning that the point is for everybody to have access to healthcare. And it's organized according to what we call the primary healthcare model. So you have a lot of community type of outreaches, and then that links to primary healthcare clinics that build into hospitals and then into smaller tertiary hospitals, smaller in terms of numbers. And so the idea is for your patient to flow from the community right through the clinics, and when they advance or get complicated within their health system, move up into specialized or tertiary hospitals. And the difference within the systems is often based on the type of professionals that you'd find, where you'd find more of your specialists in specialized hospitals and your generalist in the lower spaces. And a lot of these professionals, of up to 67% of these health professionals, are nurses. One of the biggest challenges we find with the system, even if it's ideally supposed to be accessible, is that there is chronic underfunding from the state. I think the government doesn't have sufficient funding for this, which then you see struggling with issues around infrastructure, which often is dilapidated or outdated, issues around overcrowding in those particular spaces, the numbers of health professionals not sufficient, and sometimes even the mix of health professionals becomes a bit of a challenge. So in the public health system, for you to access a specialist, it might take a bit longer in terms of time, because there could be this one psychiatrist for an entire province, which could be a different picture when you talk to the private health system, which caters for only 16% of our population, surprise, surprise, but often funded from out-of-pocket payment or via medical aid. I think you call it insurance in your country. And the quality and the standard of care is a bit higher there. The facilities are better, and there's better resources, shorter waiting time, but the pricing for that is quite high, which makes only a certain proportion of the population to have access to this healthcare sector. I just also wanted to add, because I think I have a minute or two of the 5 minutes, that again, within the country, there is a traditional or alternative healthcare system that runs parallel with all these health systems. And this is linked often to African spirituality or linked to religion. And the idea is around provision of healthcare, which often integrates a bit of herbs, a bit of rituals, and a bit of even prayers that come into spaces for healthcare, and usually accessed by Black South Africans. And in most cases, what we've seen is that they often access it parallel to the Western approach, meaning that they can go to a doctor and consult and get a prescription and still go to a traditional doctor for an additional prescription, and that runs parallel. So the future of the country, they've realized how complex this whole healthcare system is and how unsustainable it is, that it also brings a bit of a challenge in terms of universal health coverage, if you especially paid attention to the numbers of 84% of the country accessing this underfunded health system compared to 64%. And we're moving towards what we're calling the National Health Insurance, which is a situation where the government is hoping to create universal access health for all, and they fund the healthcare system throughout, so demolishing private public facilities, but creating more state-run entities that provide healthcare. So that's the future of the health system, but at this stage, it still has some bit of bits and bobs and a bit complex to put together in 5 minutes. Thanks, Tony.
Incredible. That was very well timed and really interesting. There's some key bits that we're going to be talking about actually in the class on Monday. So thank you, Champion, and we will come back to you, I'm sure, with some questions.
Yeah,
at
thanks,
the end.
Champion. Appreciate it.
Vikki, would you like to go next?
I'd love to go next. Thank you very much. So my name is Vikki Park and I'm from England. I'm from Newcastle, so I'm a Geordie, and that's in the northeast of England. So my role is Assistant Professor of Interprofessional Education and Collaborative Practice, which means my responsibility at the university I work at is leading our IPE provision for about 9 or 10 different professional students, about 2,500 students every year. So that's my role currently in the university where I work. So in terms of the United Kingdom, the provision that we have is quite complex and quite multifaceted. So I'm sure most people have heard of the NHS, the National Health System. And the reason most people will have heard of that is it's the 5th biggest employer in the world. So most people have heard of the NHS system that we have. So in terms of the way the UK is structured, how we can provision health and social care is interesting because we actually have 4 nations in the UK. And the way that those nations work, we have England, which has about 58 million people in. We have Scotland with about 5 million. Wales has about 3 million and Northern Ireland has about 2. So we're looking at about 67 to 68 million people in the UK who need access to health and social care provision. And the way that health and social care provision is delivered is essentially the devolved nations that we have lead the care that they provide. So NHS England, for example, is the provider for providing care for the NHS services in England. So we have this devolved system where in order to give localised care, it's devolved to the different countries that make up the United Kingdom. So how we actually provide health and social care system is through primary care, so GP practices, for example, through secondary care, so hospitals, social care. We also have mental health provision, and we have a lot of care inside of the community setting as well. So it's quite a complex picture. So the NHS is the largest provider of that care, but we also have private facilities. We also rely on voluntary and charitable sectors as well. And a lot of our social care provision is provided by local authorities. So these are the councils who look after our geographical regions. So the funding streams are quite complicated. So the NHS itself is 75 years old. It was launched in 1948, and we use the Bevan model of care, which essentially means that it's free at the point of contact. So this aligns very much with universal health coverage, which Champion was alluding to, and it sits beautifully with the agenda that we're all striving for equity, diversity, inclusion, accessibility, and social justice. So the model was really, if you think about it, was way ahead of its time because it was all about leaving nobody out. And our NHS constitution says that the NHS belongs to the people. And I think if you're in the UK, people really do feel that the NHS is theirs. So there is that sense of pride and there's that sense of belonging to the NHS service that we provide. So it is a government funded initiative, but that funding comes through taxation. So people like myself lose eye-watering amounts of money every time that pay packet comes in, and that money actually gets redirected into the government. So we are charged for national insurance as well, for example, which means that there's money constantly moving into the budget for the government to use in order to fund our services. So if we think about some of the positives that we have, if we go back to 1948, the life expectancy now is 13 years higher. So that's an incredible outcome. Definitely a positive that we can put back to the NHS bringing in. Other positives would be things like stroke and heart disease levels have halved, so there's some real big success stories that wrap around some of the outcomes that we can measure in terms of the provision that we've given. But with that, people are living longer. So the NHS sees 1 million people every 36 hours. Some of the actual numbers, if you get down to number crunching again, is quite eye-watering. So 2022-23, the Department of Health and Social Care spent nearly £182 billion on the provision for health and social care. So these are very, very large numbers. And about 1% of that budget comes from additional costs to us as a service user. So if I was to visit the dentist, I'll have to pay some money. If I go to the optician, I'm likely to have to pay a small fee. If I buy one item on prescription, that'll be £9.65. So that's 12 American dollars just to get one item on prescription. So they draw in 1% of funding from chargeable services, but the majority of it comes through from taxation. So that's the way that it's funded. 40% of the budget goes directly on staff costs, which I think is also a very interesting thing to think about. So 40% of that money apparently goes to staff budgets. So there's lots of positives to be had. The fact that it's free at the point of service, people in England can go and have a baby. They don't leave with a baby in one hand and a huge medical bill in the other. They just leave with a bundle of joy. It's paid for at the point of contact, which is fantastic. So there's lots of positives to be had. But on the flip side of that, the negatives that are associated are we have huge backlogs still because of the pandemic. So we have really excessive waiting lists. We have huge workforce shortages at the moment. So the latest data that I'd managed to get was that there's 112,000 vacancies currently inside of the NHS. So these are some of the numbers that we're kind of thrown around with. And the government's doing lots of things to try and overcome this. There's lots of policy being brought in. There's legislation gone through Parliament. So the legislation that was passed in 2022, we had a Health and Social Care Act, which went through Parliament. And from that, July 2022, so coming up to nearly the 2-year anniversary, we had integrated care systems created. So there's about 40 odd of them, 43, I think, something like that, across England. The one that I'm in runs from coast to coast, right across the north of England. And they're responsible now for spending the money, essentially. They have responsibility for how we spend the budgets in an attempt to streamline services and make the care more integrated. So we've got more control over how we spend the budget. So things are being put in place to try and integrate the services. And in terms of policy that we have a long-term plan and we also have a workforce plan. So you're going to love these. It's just like the pandemic end. Do you remember the messages we had in the pandemic when we had 3 things we had to do? They've grabbed on with that marketing tool. We have train, retain, and reform. So these are the buzzwords. This is the catchphrase. So this is inside of our long-term plan from 2019, and they have very, very ambitious targets to meet, such as doubling the amount of medical students that we have going through training by something like 2030. So they have big ambitions to try and navigate a lot of the problems that we have ongoing. So I think in a nutshell, the UK, it lives on the legacy of the NHS, but it's a very complex, multifaceted system which desperately needs interprofessional working and it desperately needs collaboration in order to streamline the services that we give.
Wonderful.
Thanks, Vikki.
You can never put Vikki in a nutshell. It just won't happen. She's a northern girl. But thank you so much for that. That was really eloquent. I couldn't have talked about the UK so eloquently, so I'm so glad you're here. Thank you. And now just going across my screen, Mike, would you like to share your experiences, please?
Hello. Hi. Thank you, guys. I wouldn't be able to encapsulate the health system from the Philippines in 5 minutes, but I'll try. I have heard, or Champion and Vikki have discussed key concepts such as universal healthcare, issues and successes of their healthcare systems in South Africa and also in the UK, and also the existence of traditional and indigenous healthcare. These are the things that I think I would like to emphasize when I talk about the Philippine healthcare system. So my name is Michael. I am originally from the Philippines, but now I'm based in Zurich in Switzerland. But I'll be talking about, in a nutshell, I'll try, healthcare in the Philippines. So as you know, or maybe some of you might have been, or maybe you know someone who is Filipino in the US. There are a lot of Filipinos in the United States, I'm sure. So we are an archipelago, meaning to say we have 7,000 plus islands. And you can just imagine that each island has their own culture and their own language. So that in itself makes our healthcare system very complicated or complex in a good way, or sometimes not. And talking about differences, we also need to understand that in this context, we have a lot of cultures, and we have a big disparity when it comes to classes or social classes, if you know what I mean. There are a lot of people from the working class, and then you have the middle class, and then you have the upper class. So this is very much evident in our society, and that affects how people from different classes avail of the health care services from the healthcare system. And also, like in South Africa, we also recognize the indigenous traditional healers in the rural areas because of issues on access and affordability. Our healthcare system is based on the United States. The United States of America was conduit to introducing to us a public health care system in the 1900s. So so today it is highly privatized. There is also a public healthcare system where people who couldn't afford healthcare would go to the public sector, and those who want better quality but needs to pay would go to the private sector. And it is not a secret, because I just went through a document, a public health document, that's saying that our healthcare system is fragmented. It is fragmented in many ways. Because, for example, the different professionals or different, say, disciplines are not really coordinating. They refer to each other, yes, but they are not coordinating or communicating. And another thing very important is that they are also, the healthcare system is not closely working with the social welfare system, which is very important. They do, but it's not like in a system, in a systemized way. We also have the Universal Healthcare Law, which was approved in 2022. We are late bloomers. We're still figuring out how that would work in this fragmented system and in a context where you have different social classes, for example. Another thing I'd like to emphasize, which is quite unique, maybe other countries would also relate, but the shortage of health workers, not because we are not producing graduates from universities, but because of migration. So most of our Filipino health workers, we are educated in English, and I think our English competencies or in speaking and writing and reading is good enough to work abroad, to work in the UK, to work in the United States. So I think in a major hospital in the United States, you would probably have at least one nurse from the Philippines. I think that I could confidently say that, because migration is real, and that is making our health system, you know, how to say, weak, or somehow we lack a lot of people working in the system. And maybe just to end, we are also, of course, on the other hand, we are modernizing our healthcare system. We're building, you know, lots of hospitals, and we are building a lot of facilities. But that is actually, I'm thinking that this could actually be a competition of the primary healthcare, because of the competition with businesses, with because of that. So modernization versus primary healthcare, or the use of publicly funded healthcare services. So that's my critique. And also, we also are always in a constant dilemma, talking about quality healthcare versus access, because we are talking about how can we achieve or even dream of quality healthcare if in the first place we have no access to healthcare. So this is a discussion I had with my colleagues from the primary health, and also access and sustainability. Yes, maybe we have access on the first time, for example, diagnosis and initial treatment. But the thing is, after discharge, this will always be a problem, like continuity of care in the home or rehabilitation part. And last but not least, so I had a great consultative meeting in the Asia Pacific region last week, and Gilbert was there with us. And we had this discussion in our small group about IPE being taught in the university. Good. So we're having more schools talking about IPE in their classes. But the problem remains to be when they go into the practice, when you finish your school and go into the practice, they feel like, where is this IPE? Where is this? So it's always this issue that we're struggling with, but hopefully things will be better. That's for me, Alison.
Thank you so much. Yeah, none of us are good at nutshells, are we, in this room?
Thanks, Mike. Appreciate it.
Yeah, really, really interesting though, you know, and there's some shared issues, but there's definitely some specific ones. And as you said about your workforce all getting trained up and then leaving, that must be really challenging.
And the fact that you modeled, Philippines is modeled after the US healthcare system. We're not even at the gate on universal healthcare. So you're not that far behind.
Thank you. So next on my screen is Jan-Jaap. Welcome.
Yes, thank you. Well, I'm Jan-Jaap Reinders. I'm a work and organizational psychologist from the Netherlands. And this name is plural because we're a very small country that originally consists of even smaller countries. I'm from the province of Groningen that used to be a city-state. So that's why the name the Netherlands. And there are, this is a parliamentary kingdom. We also have some Dutch-speaking countries in the Caribbean area. I'm working at the University of Groningen. And it's a northern city, old university, 1614. And I work at the University Medical Center Groningen, also big hospital, and at the Hanse University of Applied Sciences. So, and there we have a typical Dutch educational system where we have the allied health and nursing as part of the universities of applied sciences, while all the medical professions and pharmacy, etc., are organized, or they get educated in the traditional universities. So that's helpful to work for both if you are into interprofessional education. So with regard to the healthcare system of the Netherlands, we are at this moment about 18 million Dutch citizens, and we have quite some challenges. I do recognize some challenges that were already mentioned. One of them is, for instance, an aging workforce shortages, but also aging population. We have rising healthcare costs, and that's really it's going over the top. That's really a crisis. We have by 2033 estimated a workforce shortage in healthcare and welfare of about 195,000. Well, that's quite a lot for us. So we already, especially in mental health care, we already face a lot of challenges. There are great shortages, and even the basic mental health care is now, well, kind of postponed. It's really a very big problem with depression, with all kinds of mental illness. So that's an acute crisis right now. We have a bottleneck in the Netherlands, talking about challenges in regards to healthcare. We have what we call the gatekeeper. That's the GP in the Netherlands. Many years ago in the Netherlands, they had the policy that the general practitioners in the community would filter. Not a lot of people go to the hospital, to secondary care, and this way we would reduce the workload and have a more smooth workflow towards the hospitals. But it didn't really work. Also, we have shortages of general practitioners. They have too much workload, and I work in a hospital myself. My wife works in another hospital, and I know a lot of people, work with a lot of people working in Dutch hospitals, and they also have problems because when GPs have too much workload, they sometimes are not very selective, so the system then doesn't work. There is no selection sometimes. Quite often, people are referred to too quickly. So still, the hospital has to face with an increased workload, with increased waiting times. And we have certain areas in the Netherlands, northeast and south, where people are actually quite deprived from good healthcare, not just welfare. So those are very big challenges. We see rising costs from more than 770 million in 1990, but in 2021, this raised until 224,000 and something million euros, while the population is not increasing as rapidly as their costs that are rising in healthcare and welfare in the Netherlands. So we really have a very big problem. I thought, well, let's first start with the challenges and then end with the positive news. Because of this, there's much more to tell, of course, but it has to be in a nutshell. because of this, the number of grants is increasing, with specifically focusing on interprofessional collaboration and interprofessional education. You see the number of initiatives are increasing also in different educational institutions. So that's a very good thing. There also, it's not just focused on interprofessional education. We see an increasing number of initiatives all over the Netherlands, where also primary care and secondary care projects are set up, and community projects are set up. So also to facilitate more transfer between interprofessional education programs and practice itself, collaborative practice. So that's promising. We're not there, absolutely not. But you do see that the number of initiatives is very much increasing. We also have a lot of the number of successful outcomes, increased efficiency in, for instance, rehabilitation is a very good success. We see prove more and more evidence that, for instance, with maintaining the same level of quality of care, efficiency can be improved in rehabilitation. So we see also the same kind of results in hospital settings. So we have a decrease because of more efficiency, because of more of an improved interprofessional climate. That inpatient days are decreased. The same is the number of pharmacy-related, medication-related projects with positive outcomes. And the opportunities are now also very much focused on increasing job satisfaction. Because of those work shortages, we want to have a more sustainable workforce. We see that a lot of people in nursing, for instance, but also in other healthcare professions, are leaving their job, changing their career. We see more burnout, we see work stress. However, we also see, and that's the successful side, we also see very promising results with regard to increased job satisfaction. Very much also related to perceived autonomy, but also improved workflow. So yes, we have a lot of challenges. I think that's clear. But we also have very promising outcomes, and the number of these outcomes are increasing. So we hope that this is the way to go. And I think that more and more people, and you see that at the amount of potential grants, very much focused on interprofessional collaboration and collaborative practice, is in the Netherlands, is increasing. I don't know how much time I took, but I hope it's kind of in a nutshell.
But that's absolutely fine. We enjoyed every second. Thank you so much.
Thank you, Jan-Jaap.
Yeah.
Appreciate it.
And last but not least, we have John, who's going to what are you going to talk about today, John? Which country?
Well, good afternoon, everybody. I acknowledge with gratitude that I'm joining you from the traditional, ancestral, and unceded territory of the Musqueam Nation. My name is John Gilbert. I'm Professor Emeritus, University of British Columbia. I'm founding chair of the Canadian Interprofessional Health Collaborative. I was at the birth of the American Interprofessional Health Collaborative, and it was my great privilege and honor to be co-chair of the World Health Organization's framework for interprofessional education and collaborative practice. Canada is the second largest country in the world. It extends from the US border, which is 4,200 miles long, right up to the North Pole. The population of Canada is about 38 million people, spread across 10 provinces and 3 territories from coast to coast to coast, as we say. Life expectancy in Canada is about 82, 83 years at the present time. Cancer, heart disease, stroke are responsible for about 50% of the deaths in our country. And the health industry, almost like the United Kingdom, Vikki, accounts for over 2 million people. It's the second largest industry in Canada. Canada's had a very interesting development of its healthcare system, largely based on the kind of system that Vikki so articulately talked about. Nye Bevan, who I remember, but you wouldn't, Vikki, founding the healthcare system, was a huge influence in Canada. And the birth of the healthcare system, the National Medical Care Insurance Act, was in fact promulgated in 1966. It was widely supported legislation. It eliminated barriers to care. A patient had a choice of physician, and the health care of every Canadian is considered a right, not a privilege. We call it capitalism with social responsibility. The health system, Medicare, as it is now called, started actually in 1968. And as I said, it's a single payer universal health coverage. It covers all of those provincial health programs and the territories, and that would be a completely different talk. It funds personal, sales, corporate taxes. I mean, the funding comes from personal taxes, sales, corporate taxes, and federal transfer payments. And the federal government only provides direct services to special populations, military, Native Canadians, that's our Indigenous population, and federal prisoners. The rest of the healthcare system is managed by each province and each territory. And so each province and each territory receives funds from the federal government to organize and operate its system. It's very complicated, as complicated as any healthcare system I've ever seen, but that's the way it is. In 1984, the federal government instituted federal health insurance legislation, and that established criteria, conditions that are related to insured health services, what we call the national standard. And provinces and territories must meet those national standards in order to receive the full amount of their federal cash transfer. Remember, I said the money comes from the feds back to the provinces. Historically, insured services are largely restricted to care delivered by hospitals or by physicians. So as Vikki has said about the National Health Service, if you need eyeglasses or dental work or pharmacy or hearing aids, you have to pay for those yourself. Although we have just instituted federal coverage for dental care for everybody up to 20 years of age. There's a bit of a fight about this. We are about to introduce universal pharmacare, which was probably about a year away. And last year, the federal government introduced within the social care system an agreed on fee for primary daycare settings. Very, very important, as seen as a gender issue, allowing women to go back to work without the onus of having to find extra fees for daycare. So the Federal Health Act 1984 was very, very important. That legislation very important for setting the standards. As Vikki said about the National Health Service, so we're publicly funded, but some of the things that are done in that system are privately delivered. So the governments have decided that lab work need not be done in hospital, not all lab work need not be done in hospitals. So that has been contracted out to private deliverers, but they are paid by the healthcare system. The same is true for x-rays and CT scans, et cetera. All of those things that look as though they are taking up time and space within the acute care system are now outfunded to private organizations, but still funded by the health system. Most of healthcare services are free at the point of use, but the physician is seen as a private provider. So physicians are essentially entrepreneurs, but they get paid by the government for delivering those services. It's a very complicated problem. Vikki and I could have a very interesting chat about this particular issue. And so provinces then are constitutionally responsible for the administration and delivery of healthcare services. The provinces, constitutionally responsible. The feds set the standards, the provinces accept those standards, they get funded to carry out whatever the services are under those standards. And like every healthcare system or health and social care system in the world, we have lots of concerns about the future of healthcare. Despite all our best efforts, there is inequity across provinces and territories. It's absolutely understandable. Remember, we are going from the US border to the Arctic Circle. And it's not surprising that in some places we simply cannot get in the kind of care which is necessary for those communities. We're working at it, but it's still a problem. We, like everybody else in the world, are increasingly concerned about the number of elderly citizens that we have. I think I'm going to count myself amongst that number. So, you know, we have a big problem, but every country has this problem. And how are we going to deal with it? We're still working at it. But the Canadian Institute for Health Information, which is our great statistical powerhouse around health and social care in Canada, has just produced a very good report on this issue, which is now going out to the provinces for consultation and review. Lastly, we are very concerned, well, there are other things, but let me just say lastly, we're very concerned about cost containment efforts. You know, we spend federally about 12.5% of our budget on healthcare. Provincially, that is the province of British Columbia in which I live, we spend about 42% of our budget on health and social care. That's not sustainable under any conditions. So there have to be efforts made, we understand this, to contain costs. And that means looking at the global budgeting programs that we have in place between the feds and our provinces. And one of our concerns, and it's a concern regardless of where you look in the world, is that if the costs get out of line, then that's going to interfere with the adoption of new technologies. And we know that new technologies make a huge difference to health and social care. So for example, the electronic health record, you know, that was going to be the kind of holy grail of organizing data within health and social care, has proven to be a huge problem financially. Canada has already spent about $5 billion trying to get this right. And so, but we have to get it right. Everybody's health record needs to be transportable, you know, maybe in a chip in your wrist or something like that. And we're not there yet, because if you get sick on the other side of the country, let me take the province of Nova Scotia, which is right on the Atlantic coast, there's no way you can get my records to that place, and there should be a way. So those are our three big concerns: inequity, increasing elderly, and cost containment in order that we can afford to buy the new technologies that comes online. Thank you for your attention. Thank you for inviting me. All my relations.
Thanks, John. Appreciate it.
Yeah, did you say you wanted to ask a question?
Yeah, I want, we do have some questions from the students, so I don't want this to take too long, but one of the themes of our course is global interdependence. So, you know, and we were all together in Qatar at the Altogether Better Health Conference. If you were to think one thought, when you think about global interdependence in healthcare, you know, I would like anyone who'd want to speak to you know, what do you think of when you think of global interdependence? What issue, you know, what primary problem can be addressed that impacts global interdependence? Anybody like to speak?
Oh, I'll just say, if there's one thing that has really pushed this up to the top of our consciousness, every one of you can guess what it is, right? We just are not through the pandemic yet. We have to put all of our resources together. No, oh, we're a developed country, we're going to keep it all for ourselves. That does not, we are going to have another pandemic. So for me, in my aging years, that's what concerns me most, getting that kind of coalition, cooperation, collaboration around being able to provide care regardless of where you are in the world when we have something like a pandemic. Thank you.
Anyone else want to chime in on that?
I can, beside indeed, absolutely agree with John with regard to sharing resources. You know, together we have much more to give, and also with regard to learning. Diversity is the largest learning potential. It's not being the same; it's being different, and people have different answers, different solutions, different inspiration based on their own context. So the way we look at healthcare, as we always did, it has to transform, it has to change. And besides the urgency, change also means that you have to think in another way. And I think that diversity is a very strong solution. I think that's very much aligned with what John is saying. And this also means that we have to share those resources. And besides this, but this is also related to resources, is you know, I just call it inspiration. But for instance, remuneration systems and funding. You know, we talked about this complexity, and you see this all over the world. People have those problems with it. And as a psychologist, I see this money also as a stimulus. So you can have different kinds of stimuli. If you want to change, if you also want to support a collaborative system, then how can we use funding and remuneration? What's the method to use this? And can we learn from one another that can really also be an incentive to collaborative behavior? It's not only intrinsic, it's not only competence, it's not only workflow, it's also the environment. It has to be a habitat where interprofessional collaboration can be propelled. So that would be my
That's great. Thank you very much. Do we want to have maybe some of the student questions?
Yeah, if that's okay. Yeah, we've had quite a few. So the first one we got through was, if you had to choose something to change about the healthcare system in your country, what would be the first thing? Just one thing, real small nutshell, everybody.
Right, tiny nutshell, Alison. Because our patient numbers are going up and our staff numbers are going down, we're having a post-pandemic exodus of staff. And one of the biggest reasons the staff are leaving is because we celebrated them in the pandemic. I don't know if you saw in England, we got pots and pans out and banged every Thursday because we were so happy with everybody. And now the government won't give them a pay rise. So the thing that I would change would be that reputational damage for the health and social care professions, and also value in them. And really, the government really needs very seriously to celebrate how experienced, how qualified, how knowledgeable the workforce actually are, because at the moment they're feeling very undervalued. So that is the thing that I would actually want to address straight away: value the staff that we have, retain.
I think we could do a whole different extra global panel around that, couldn't we? About, yeah, making people feel good in their job, so they're going to stay in their job. Yeah, thank you, Vikki. Anyone else like to add their thoughts?
Champion, maybe something you change within your system.
I can come in here. Sorry about that. I think what really strikes me quite a lot, and I think when I saw that question, the first answer was I could change a lot. That could be the one thing I could change. But I think from a practical perspective, we're sitting with an extremely fragmented and extremely disintegrated health system, which is not literally serving its, I mean, it's not doing its purpose. That's the whole thinking that's happening. And you could look at it from a macro level on how to build this whole bigger models of healthcare provision. But how do we look at it as an integrated health service that is there for every person who's in South Africa, which is quite a big problem, considering the history of the country and where it comes from. It feels like we're sitting in a country which still perpetuates this whole separation of the haves and the have-nots, the rich that can afford quality private healthcare systems, and the poor that still sit in in long queues with poor service and underfunded spaces, and that's 84% of the population. So if that can be reimagined on an integrated system, that's a health for all. I think that could be a starting point.
Thank you. Can we talk any more? Or are we nearly finished?
We can,
We're nearly out of time, aren't we?
is there, Mike, is there anything you'd like to add to either of the two questions we asked so far?
A lot needs to be changed. But I think one thing that I'd like to change is for people to have more access or ability to access healthcare. I think that's number one for me.
Fantastic. Thank you all so much. So do I need to wrap up now?
All right.
I wonder whether, would you
just-
mind? Yeah, carry on, John. Yeah.
Yeah, so Abigail Francis asked an interesting question. Can I just respond to Abigail? She said, is Canada healthcare cheaper than most countries? And do you think America will ever do what Canada does? Well, Canada healthcare is not cheaper than other countries, but it's cheaper than the United States by about 7 percentage points. The best measure of any health social care system, in my view, is maternity and maternity health. You know, infant deaths. If you have to count, you have to do it by that metric. One of the best systems that I see in the developed world, I don't know, Jan-Jaap or Vikki, whether you'd agree with me, but France, I think, has an exceptional healthcare system, health and social care system. It is very well organized. It is socially based. It really takes care of every citizen. I think it's a model that we try to do in Quebec, which, as you know, is our French-speaking province. But that's a very interesting question. And the metrics that we use to say, is it more expensive or is it cheaper, are worth a lot of discussion. But thanks for allowing me to answer the question.
Yeah, I think the cost of not guaranteeing care ends up actually driving up the entire cost of the system. You know, I think when you make it so that it's inequitable access to care, that care still happens. It just is much more expensive.
Yeah, and I think it's important to say that, you know, healthcare is not a cost. People keep talking about the cost of healthcare. Actually, if you have good healthcare, it's a huge benefit, you know. And so if we do the return on investment, which we should be doing, we would see, as was shown in the world, I think it was the United Nations report of 2015, that actually the return on investment is huge. Good healthcare goes with good education, goes with increased productivity, et cetera, all of those other things. But thanks.
Thank you. I was wondering whether, oh, go on, Jan-Jaap, please.
Oh, yeah. I also saw a question about mental health care in the Netherlands. So currently we have it's a while about how it's currently working or not working in the Netherlands. So as I said before, the general practitioners in the or had the family physicians in the Netherlands, they are kind of the gatekeeper and try to find additional solutions to for people with relatively less sincere or less mental illness, you know, like for instance, like small depressions, not acute mental crisis. They try to allocate more to social work, for instance. They try to implement more are actually implementing projects where they use peers to help one another, especially in the case of depression. But the basic mental care that would normally be given is now absolutely shut. It's not possible. It's not possible to get any mental health care unless it's more acute, unless it's more yeah, as I say, acute. So So that's the current position of mental health care in the Netherlands. So the GPs, again, who already have too much workload, have to deal with this. Social work gets a more prominent role in this. So these are, you know, temporary solutions, and still a lot of people are at home and don't get any help. That's the real situation.
Great answer. Thank you. Also, all the students who asked questions in the chat, and I appreciate the panelists for answering them in the chat, the ones you can. They'll get a bonus point for this class. So thank you. We didn't get to your questions, but we appreciate that. So
Yeah, definitely. And we want to say a huge thank you to our global panel. I just found a few photos of us from Doha, and just to show the students really how literally interprofessional education and collaborative practice, it is global. We're all global. We're all such good friends as well now. It's such a wonderful thing to be a part of. And long may it continue. You're all going to be the practitioners of the future. So please take these core values with you, because it will make a difference on the ground floor. But I'm sure you'll want to join us in thanking our esteemed panel. You were incredible, as we knew you would be. We went for the top dogs. So thank you all so much for your time, and we will be asking you to do it again. So be prepared. But thank you so much.
thank you.
And for us. Thank you. And for our students, there are 2 questions on the discussion board, which you'll be able to see on Canvas anyway. I don't need to dwell on that slide. Students, when we meet up on Monday, there's so much we can pull from today's session. It was as though we planned it. So thank you. Again, thanks to our panel so much. And we will hopefully see you all very soon. But thank you.
Thank you. Thank you. Thank you.
Have a great
seeing
day.
you all.